We would like to take another moment to thank our sponsors, whose financial support helps make CapTime's Idea Fest the important event that it is. Special thanks to our presenting sponsor, UBS, the Burrish Group. They have been a major sponsor since the very first Idea Fest. Major sponsors include HealthX Ventures, Exact Sciences, and Quartz. Co-sponsors are Madison Gas and Electric, Godfrey and Kahn Law, the University of Wisconsin-Madison, and Epic. Our Friends of Idea Fest sponsors are Wisconsin Alumni Research Foundation, Madison Community Foundation, University Research Park, Cargo Coffee, Doc Smokehouse, and Forward Theater Company. Our media partners are the Wisconsin State Journal, Madison.com, WKOW Channel 27, and Hinckley Productions. Again, we thank you for your support and for making Idea Fest 2021 a huge success.
Hello, I'm Paul Fanland, editor and publisher of the Capital Times, and I'd like to welcome you to CapTime's Idea Fest. This is the festival's 5th year and features both live and virtual sessions. Our theme is Reckoning with Change, and there has certainly been a lot of that. Staging Idea Fest is always a big lift, and we couldn't do it without our generous sponsors and CapTimes members. If you're not already, I hope you'll consider becoming a member. Members help shape our events like this one and support an independent local media organization at a critical time. Find details online at membership.captimes.com. You'll find other festival videos and information at captimesideafest.com. I'd like to thank the Burrish Group at UBS, which once more is the presenting sponsor of Idea Fest this year, as well as many other sponsors. This session features an all-star panel discussing how advances in science and technology are transforming cancer detection and treatment. It is sponsored by Exact Sciences, which has supported us since we started in 2017. We are very grateful, so please enjoy the conversation.
Well, welcome everybody. Thanks for joining us for this panel on cancer screening and diagnostics. I'm Jo Handelsman. I'm the director of the Wisconsin Institute for Discovery at the University of Wisconsin-Madison. Wisconsin Institute for Discovery is a cutting-edge research facility that emphasizes multidisciplinary approaches to difficult problems across all of our challenges in medicine, agriculture, and the environment. I'd like to introduce my very exciting all-star panel of experts today to discuss the future of cancer care and how the advancements in science are beginning to change how cancer is detected and treated. So let's meet my panelists. First of all, from the Mayo Clinic, we have Dr. John Kissel. Dr. Kissel and his team focuses on work on identifying molecular markers for invasive cancer screening and surveillance to advance early detection. Welcome, Dr. Kissel. Could you tell us a little bit about your work and what a biomarker is?
Yeah, thank you. Please call me John. I'm a gastroenterologist, which is a physician specializing in diseases of the gastrointestinal tract and liver, and colon cancer prevention and treatment is the main focus that I have within that field. And that's how I came to be involved with the research team that at Mayo that collaborated with Exact Sciences to develop the multi-target stool DNA test, or Cologuard. And under the guidance of my late mentor, Dr. David Ahlquist, we began applying biomarker technology like that in Cologuard to detect other cancers. And that brings me to your second question, which is, what is a biomarker? And this is a measurable chemical or biological substance in an organism or a person whose presence is indicative of some type of phenomenon like a disease or an infection or an exposure. And we've come to learn a lot in recent decades about these measurable substances and how they can be indicative of cancer and how we can use those substances to treat or even prevent the onset of cancer, individualize therapies, make sure that patients have been successfully treated, and monitor for signs of relapse. So we can use these tools really across a wide continuum of care for patients.
Thank you, John. We'll hear more about your work and your ideas in a bit. Next, we have Jake Orville, who's the General Manager of Exact Sciences Pipeline Business Unit. Welcome, Jake. And can you tell our viewers a little bit about Exact Sciences and the role that the company is playing in the fight against cancer?
Sure, Joe, and thanks for the opportunity to be on this amazing panel with Sung and John Kissel. Exact Sciences is a leader in diagnostics focused on oncology. We've had a plus decade-long relationship with the Mayo Clinic, as John Kissel had described, as well as other collaborations with leading institutions across the country. What started for us as a mission to get more people screened for colorectal cancer through our product that most people know called Cologuard, discovered at the Mayo Clinic and brought to patient care through Exact Sciences, has now blossomed into a big, bold mission of detecting cancer early, eradicating cancer and all the suffering that it causes. We've now blossomed out beyond just colon cancer detection and Cologuard, and now are working on very innovative tests, or as John said, biomarkers along the cancer care continuum. Getting more people screened has always been the mission of our company. Now, for those unfortunate that were diagnosed with cancer, continuing to give those patients and those providers that are seeing those patients the tools, the information, and the testing that they need to properly manage patient care in that cancer care continuum is really what we're after. The pipeline at Exact is just that. We're looking at tests now in prognosis and diagnosis. We're looking at things in therapy selection, and even things like whether you're going to recur or minimal residual disease. That's the pipeline at Exact Sciences that now goes well broader than what most people know us for, which is Cologuard.
Thanks, Jake. Very exciting. And our third panelist joining us to represent patients and families impacted by cancer. We're fortunate to be joined by the CEO of Stand Up to Cancer, Sung Publietti. Sung, tell us a little bit about what you've been working on.
Thank you, Joe. Stand Up to Cancer's mission is to raise significant funds to accelerate the pace of groundbreaking translational research that can get new therapies to patients quickly and save lives now. Stand Up to Cancer brings together the best and the brightest researchers and mandates collaboration, cooperation, and communication amongst the cancer community. By galvanizing the entertainment industry, Stand Up to Cancer engages the public to increase awareness about cancer prevention and to highlight progress being made in the fight against the disease. Since inception in 2008, Stand Up to Cancer has generated pledges of over $750 million that allow us to fund more than 1,950 scientists representing more than 210 institutions. And we are truly grateful to the entertainment and media industries for the constellation of assets donated to us. And of course, to over 900 celebrity ambassadors who stand up to cancer with us.
Thank you, Sung. So let's turn to some questions about the future of cancer and detection and screening in particular. John, maybe you could tell us how things are changing. So historically, cancer was detected primarily through symptoms. And as you talked about, biomarkers, diagnosis, and now even treatment are beginning to move in different directions. Do you want to tell us a little bit more about how those changes will manifest in the next decade?
Yeah, absolutely. Great starting point. So, unfortunately, detection by symptoms is still the present state for many cancers that we cannot screen for. So at present, really screening for colorectal, cervical, breast cancer, and some lung cancers is practiced in persons who do not have symptoms, because these diseases are common enough in the general population that we ask everyone beyond a certain age to be tested for those regularly. The cancers that we don't screen for are less common, and screening for these individual cancers in organs like the pancreas or the ovary or the esophagus would, with present technology, find very few cancers and generate a lot of false positive tests. So this means a lot of cost and a lot of anxiety. Also, anatomically, these cancers occur in organs in the dead center of our bodies, and they require invasive testing like endoscopy or sometimes even surgery to adequately diagnose and evaluate them. Unfortunately, when symptoms do develop, that typically indicates that a cancer is at a more advanced stage. That means larger tumors, spread of that cancer to lymph nodes or distant organs elsewhere in the body. And when that occurs, cancer is much harder to treat and much more difficult to cure. So therefore, we really need to get to a future state where we're not relying on symptoms, and we can use screening tests for much more cancer types than those we currently have screening solutions for.
So early detection is important because it reduces fatality?
That's exactly right. So simply put, the earlier we can find a cancer, the more likely we are to be able to treat it, to improve quality of life, prolong quantity of life, and potentially even cure the disease.
Thanks. So Jake, Exact Sciences is one of the companies pursuing a blood-based multi-cancer screening test. I was really excited when I heard one of your colleagues talk about it a few years ago. I think they call it liquid biopsies. And that seems like the next big step. Can you tell us a little bit about that, and what's your vision for the future of multi-cancer screening by liquid biopsies?
Sure, Joe. And liquid biopsy is really a fancy way of saying a blood test. We're now able to detect things in the blood. If you think about the advancements over the last decade in cancer biology, technology, computing, algorithms, data, this is all coming together now in a way that we've never seen before. I think what was science fiction just a decade ago is now science reality. And we now have the tools, we now have the chemistries, we have the technology, we now have more advances in sequencing. We can see as little as one tumor DNA molecule in blood. Finding that needle in a haystack. That's what we're really out to do. And just to put a pin in the comments that John said, the 5-year survival rate for those detected early is 9 in 10 survive. The 5-year survival rate for those that are caught late when that cancer spread is 1 in 10. Think about that difference, 9 in 10 and 1 in 10. That is so significant that we think that there's really, as great as these therapies have come to market, immunotherapies, targeted therapies, there's still no therapy as effective as early identification and early treatment. And that's what we're after. So to John's point, looking at all these cancers in aggregate as an individual cancer at a time is really very challenging. The cancer screening modalities that John just mentioned, breast, colon, cervical, prostate, and high-risk lung, that still only accounts for 30% of the cancers diagnosed on an annual basis. Think about that. With all the advancements I just described, we're still only have the tools on a routine basis to detect 30% of the cancers that are diagnosed annually. So what happens to that 70%, that staggering amount of people that are not, they don't have routine screening mechanisms. They're detected, as John mentioned, through signs and symptoms. That's what we're really out to address. Looking at those individually, one cancer at a time, is going to be a tough journey. It's going to be difficult, costly, expensive, and just may not work, which is why we're looking at this thing called multi-cancer early detection. And that's looking at all of these cancers in aggregate in a simple blood draw, using those advanced technologies that I'd mentioned to find those needles in a haystack and aggregate those cancers together to provide a better screening modality so that we can address that gap, that 70% of people that still don't have a routine screening modality that they're part of. That's really what we're out to do, and that's what we're committed to in our multi-cancer early detection program.
Thanks, Jake. Really exciting. Let's turn to some of the communities that are disproportionately affected by cancers. Last year, the death of Chadwick Boseman brought quite a bit of attention to the issue of colorectal cancer in Black populations in the United States. So what are some of the issues that contribute to those disproportionate effects on certain communities, and what can be done about it? Sung, would you like to take that?
Absolutely. These communities we're talking about include Black American, Hispanic, Latinx, Native American, Asian American, socioeconomically disadvantaged, rural, and LGBTQIA communities. Racial and ethnic minority populations have long experienced cancer health disparities. And for example, Black Americans have had the highest overall cancer death rate of any racial or ethnic group in the United States. For Hispanic Americans, cancer is the leading cause of death, accounting for 21% of deaths. And regardless of ethnicity or race, social determinants of health have a major impact on people's health, well-being, and quality of life. So what do I mean by social determinants of health? Some examples can include safe housing, transportation and neighborhoods, racism, discrimination and violence, education, job opportunities and income, and even access to nutritious foods and physical activity opportunities, to name a few. Just as significant are fear and perceptions about cancer and distrust of the medical system. Culturally sensitive patient engagement, training, capacity building, and multi-stakeholder collaborations around new innovations such as liquid biopsies, informed by a health equity agenda, are key next steps toward building a momentum to optimize the public health impact of these emerging technologies. And you mentioned Chadwick Boseman, the attention that was brought to colorectal cancer and its impact on communities. The news of Chadwick Boseman's death elicited widespread shock and grief, not only in Hollywood, but in many communities where colorectal cancer was hit hardest. Black and Hispanic Americans are typically diagnosed at a later stage in the disease when it's more difficult to treat. So this goes back to what Jake mentioned in terms of statistics. 9 out of 10 people survive when cancer is detected early. When it's detected later, there is so much more fatality. And in particular, in Black Americans, they're about 20% more likely to get colorectal cancer and about 40% more likely to die from it than most other racial groups. These conditions cannot be allowed to persist. And it's really incumbent on the medical community to create a healthcare system that serves all patients equitably. And society has a role to play in helping this occur. And what an opportunity for all of us. Today, medical science and industry are testing or perfecting a raft of new diagnostic tools, such as non-invasive ways to detect multi-cancers. Our challenge for all of us is to make sure that these new technologies are not deployed in the same inequitable patterns of the past.
Thank you. That was very depressing, but hopeful that people are talking about the inequities these days. So we've heard a lot about how late detection can be fatal or make cancer so hard to treat. John, could you tell us a little bit about the biology of that? Why is cancer so hard to treat?
Yeah, so that's a great question and a frequent source of confusion for patients in particular. And the central problem really is that cancer arises from our own tissues and cells. It's part of us, and so surgically removing that cancer can be helpful, but can't be done if the cancer is too close to or wrapped around an irreplaceable part of the body, like certain types of blood vessels, for instance. And also, if the cancer has spread outside of its primary location to other parts of the body, then removing that tumor may not even help a person live any longer than they would have without surgery. Even when surgery is possible, the biggest threat from the cancer often arises from microscopic disease spread that we cannot see, even with the most powerful diagnostic equipment. And this is a phenomenon that Jake raised earlier called minimal residual disease. And when this is present, microscopic disease is not removed, then the cancer can rapidly recur even after surgery. And so that's why we use additional tools like chemotherapy or radiation therapy, either before or after surgery, to consolidate or clean up the cancer cells that we suspect may be present but can't see. Unfortunately, chemotherapy and radiation are toxic to healthy tissues, and using these treatments safely and effectively is a serious balancing act that requires teams of trained experts working together in an integrated fashion. So that's really why cancer is difficult to treat, especially as it gets more advanced.
Thanks, John. Jake, I wonder if you can share some corporate secrets with us and tell us about some tests that are being developed that maybe the public doesn't know about yet.
Well, I certainly can't do that, but I will emphasize some of the amazing programs that we have that have been disclosed that we are working very hard on. We have three primary focus areas today. That is to continue to improve the ability to bring non-invasive colon cancer screening into patient care. Cologuard has done wonders. 6 million Americans have now been screened with Cologuard, half of which were never screened before. That's just a testament to making these accessible, non-invasive, at-home solutions, especially in our current state in the pandemic, and making this easy. So we will continue to progress and be leaders in the non-invasive colon cancer screening. We're working on improving our Cologuard product. We're working on bringing a blood-based colon cancer screening test to market to make sure that we meet the patients where they want to be met. Some patients want to do non-invasive activities at home. Others are in their physician office for their annual physical, and it may be easier to get a blood test. So that's kind of focus area number one. The second we've already touched on, which is multi-cancer early detection. That's another big area of focus. Exact acquired a company in 2001 called Thrive Early Detection. This was a company spun out of Johns Hopkins University. And this is the company that was working on that very unique and proprietary technology to see those needles in a haystack. This is also the company that did the only prospective interventional study for multi-cancer early detection and demonstrated that they could double the number of cancers detected early through a simple blood draw in combination with the current standard of care. And so multi-cancer early detection, which we've already talked about, is a huge focus. We have a whole group and team of people, plus a new acquisition here at Exact. And then the third area, just mentioned by John, is this concept that he had described called minimal residual disease, or also looking for recurrence. Because of the tools, the technology, and the science, and because of our great talent that we have here at Exact, and some of the acquisitions or licenses that we've done recently, we've been very active. Again, we have technology now that allows, as John described, to look at the circulating tumor DNA to see if post-surgery or as you're going on therapy, did we get it all? And is it coming back? Studies have demonstrated that you can see circulating tumor DNA up to 9 months ahead of what you would see on an image. Now, think about that for a cancer patient. Think about a cancer patient who's gone through surgery, who's on treatment. Their worry is, did you get it all? And is it coming back? And let's find it as quick as possible. The fact through a simple blood draw for these cancer patients that we may be able to see this circulating tumor DNA at a very low level, that needle in a haystack, gives them the confidence that we'll be able to follow them, we'll be able to continue to treat, and that we at Exact will continue to give the providers, these oncologists, the best tools they can to manage the patients. So, Joe, those are the three areas: leaders in non-invasive colon cancer screening, bringing multi-cancer early detection to market in a very scalable and thoughtful way, and then give these tools for minimal residual disease to the oncologists that are managing current cancer patients.
Wow, that sounds like an entirely new era for cancer. Very, very exciting. Sung, I worked for several years as a science advisor to President Obama. And one of the things we did was to launch his precision medicine initiative. And I was, of course, very excited when one of the events that we had to launch that brought Stand Up to Cancer to the White House, and the representative. I wasn't that excited about Stand Up to Cancer, I have to admit. The exciting part to me was Pierce Brosnan came. To represent Stand Up to Cancer. And actually there were several TV stars and athletes representing Stand Up to Cancer. And recently, I think you've developed an alliance with Major League Baseball. Can you tell us a little bit about how those public initiatives and bringing in celebrities affects the awareness of cancer, and perhaps also destigmatizes talking about cancer, which is an ongoing issue?
These types of collaborations are very important because we have the opportunity to amplify messaging that healthcare providers share with their patients, and also destigmatize talking about the C word, cancer. Since our inception in 2008, Major League Baseball has been a founding supporter, providing funding and year-round promotional support, including the iconic placard moments at the World Series and All-Star games. It's really hard to overstate the moments, what that really means when everyone stops, puts their rivalries aside, and pauses for a beautiful display of human connection. During these few minutes, we are one because we have all been touched by cancer. We know from the fans, their letters and emails, that this has helped people talk to their doctors about screening or seeking out clinical trials as part of their treatment, and lives have been saved. Our work with MLB is only one way we bring awareness about cancer. Creating national public service announcements across top print, broadcast, radio, digital, and out-of-home outlets is another way we leverage our entertainment industry assets. This is one way we engage our celebrity ambassadors for national campaigns and social activations, and work with community organizations and influencers to extend our reach within local communities. And our Academy Award winner, Jamie Foxx, on colorectal cancer screening is appearing nationally as we speak. It's critical for people to know their options and what tests and treatments are available so that they can make an informed choice.
Thanks. And of course, that also makes great memories for people like me who got to meet some celebrities. Why don't we take a break in a few minutes? But before we do, maybe each of you could answer the question of what could we be doing better in cancer detection, screening, and future treatment? John, do you want to start?
Yeah, I think there are really three major obstacles. As Jake mentioned earlier and Sung as well, that not enough people who are eligible to participate in screening are doing so. That includes through lack of awareness, willful avoidance, or healthcare disparities. So even in the wealthiest country on earth, people simply can't access screening, and we have to change that. We're seeing worsening rates of incidence and death in the cancers that we can't currently screen for yet. And the successes that we are seeing in terms of getting a hold or getting ahead of cancer are primarily limited to countries and health systems that are rich in resources. So, we talked about healthcare disparities in the United States, but cancer incidence and death are also skyrocketing in other parts of the world due to environmental exposures like smoking or endemic infectious diseases, worsening rates of obesity. So we really need to find ways to make new prevention and early detection and treatment options scalable and deliverable in low and middle income settings.
Great. Jake, you want to take that question? What could we be doing better?
Sure. John stated all the areas that I think are crucial in this. So not to repeat that, I guess I would add just a focus on clinical studies. All of the discoveries at the bench need to come into patient care. And in order to do that, you just don't make them available. You have to enroll patients in these massive clinical studies that demonstrate both the specificity and the sensitivity, or the how efficacious they are and how safe they are. And getting people enrolled in clinical studies was always a challenge prior to a pandemic. It's now an increasing challenge with a pandemic. We want to prove that these tests don't just work, but we want to prove that they work in diversity, which includes geography, race, and gender. We want to make these tests not just accessible to everyone. We want to demonstrate that they perform well in everyone. And in order to do that, you've got to have a diversity in your clinical trial population. And if clinical trials are harder to enroll, people are more challenged or more afraid to enroll, it just makes these amazing technologies that we now have at our fingertips just more difficult to bring into patient care to get through those studies. So we need to think of innovative ways virtually. We need to think of how we go to patients versus helping them come just to us. And everyone knows someone with cancer. Everyone should also be raising their hand and saying, I want to participate in a clinical study, whether they do or don't have cancer, because that's really how we're going to be able to advance these technologies forward.
Great. Sung, what do you think we could be doing better?
Well, I just want to add to what John and Jake stated, and it's really about us meeting communities where they are. We need to recognize that communities receive health information and media through a variety of channels and utilize established trusted message delivery options. We have to have trusted messengers and validated messaging to reach people with cancer information. It's the only way we're going to help close that equity gap. And we have to work together across sectors to establish and earn trust from patients and their families. What I love about our discussion today, the innovations that we're talking about is being led by science. And I think that's a great place to start.
Great note to take a break on. We'll just take a short break and we'll be back in a few minutes. Thanks to all our panelists.
We would like to take another moment to thank our sponsors, whose financial support helps make CapTimes Idea Fest the important event that it is. Special thanks to our presenting sponsor, UBS, the Burrish Group. They have been a major sponsor since the very first Idea Fest. Major sponsors include HealthX Ventures, Exact Sciences, and Quartz. Co-sponsors are Madison Gas and Electric, Godfrey and Kahn Law, the University of Wisconsin-Madison, and Epic. Our Friends of IdeaFest sponsors are Wisconsin Alumni Research Foundation, Madison Community Foundation, University Research Park, Cargo Coffee, Doc Smokehouse, and Forward Theater Company. Our media partners are the Wisconsin State Journal, Madison.com, WKOW Channel 27, and Hinckley Productions. Again, we thank you for your support and for making IdeaFest 2021 a huge success.
Well, welcome back. We're here with our experts, Dr. John Kissel, Jake Orville, and Sung Pavletti, to talk about the future of cancer screening and diagnostics. So one of the things that has always struck me about cancer is the number of misconceptions. And I guess it goes beyond cancer. We've certainly seen many of these during the COVID epidemic. Misinformation, wrong information, easily propagated rumors that people like to believe. Can any of you tell us about some of the misconceptions about cancer?
Jo, not only will I tell you the biggest myth I hear about cancer, it's going to be optimistic and hopeful. What I hear is that cancer is not a preventable disease. There's a fallacy that cancer is mostly controlled by genetics. Genetics does play a role in whether or not you'll develop cancer, but most experts agree it accounts for less than 20% of cancers. More importantly, lifestyle and the environment plays a major role. And to quote my wonderful friend, Dr. John White's new book on cancer, we need to change the way we look at cancer from, I hope I don't get cancer, to how I can prevent cancer. Believe it or not, we have the power to reduce our risk of many cancers. There's more data now than ever before as to what you can do, what you need to do in order to prevent a cancer diagnosis. And in fact, up to 50% of cancers are likely preventable by eliminating risk factors and undergoing recommended screenings. This doesn't mean you can completely prevent cancer, but you can certainly improve your chances. Some of those risks you can change include your diet, alcohol consumption, tobacco use, and physical inactivity. And just to tie our wonderful discussion all together, screening is a critical factor to help people identify cancers before they've had a chance to take hold or spread. And awareness, the first step to be empowered with the knowledge that will allow individuals to take action.
Yeah, I'm reminded of one of the events that occurred when I was in the White House. The then Vice President Biden stood up the moonshot for cancer. And some of my staff were actually pulled away to work on that. And they began to focus very heavily on treatments. And that got out into the press. And one of my colleagues who had cancer, but also was an expert on it scientifically, called me up and just railed about that and said, we could be preventing half of cancers just by a few small changes. And that's what they should be working on. And I took that to the Moonshot group, and I never knew if they incorporated it or not. But then after the White House, when I got to Madison, I was, of course, very excited to be in the same city with Exact Sciences, which focuses so much entirely, in fact, on prevention and detection. So it's really great to hear that transition away from the awful treatments that we all hear about and the aggressive surgeries and chemotherapies, and more toward prevention through either lifestyle or detection. So that's a really great perspective. Any other misconceptions that anyone wants to address?
I'll build on Sung's comments in that in addition to preventative lifestyle interventions, there can be medical interventions like vaccination for diseases that cause cancer, like hepatitis B and human papillomavirus, which is recommended for teenagers and young adults, a population we don't think about at all with respect to common cancers. I think also the revolution of sequencing the human genome has given us new insights into being able to identify individuals and families that are at increased inborn risk of cancer. So family history, taking a pedigree, remembering what happened to mom and dad and grandma, often misses the large majority of people who carry hereditary cancer risk and don't know. So that's why I think it's really important not to rely on that family history to get screened. But often I think now we're going to start seeing the implementation of genetic risk profiling to help patients so that we can follow these families more closely to help catch cancers early and offer preventative lifestyle measures or even preventative prophylactic surgeries.
Anything else on misconceptions? At least people talk about cancer now. The oldest misconception I can remember is when people wouldn't talk about it. I remember my grandmother always saying that somebody was sick and then going like this. And she just wouldn't say another word if it was cancer. And I never understood what that meant, but I think it was partly the fear of the disease. And we've opened up the conversation to reduce some of that fear. I think that's really big progress. So I think we can't spend enough time on diversity, underserved populations, and addressing some of the inequities in cancer treatment, medicine generally, but specifically cancer detection and treatment. So I wonder if any of you would address that further, and what are we doing at the medical level or in terms of information or anything else to address inequities across the world and also within the United States?
Jo, I think we should go back to the numbers. When cancer is detected early, 9 in 10 survive. When cancer is detected late, when it's spread, unfortunately, only 1 in 10 survive. I think that's our North Star. And that quote that I said earlier, that there's still no therapy as effective as early detection. And I think that's what we need to focus on. Our mission at Exact is to get all people screened and make sure that everyone has and are up to date with their screening, and that we're bringing innovative tests that are easy to all populations. We think of 3 very key factors that are needed to come together to achieve this mission. They are accuracy, adoption, and access. So first, with accuracy, in order to make the impact we know we need to make, we've got to make sure that these tests we're bringing forward are accurate for all populations and all geographies and all genders and all races. That comes down to clinical trials and clinical trial enrollment, and making sure that we're not just showing the accuracy of these tests in one population or in one part of the country, but that we're enrolling, like we have at Exact, hundreds of sites all over the country. Now we're even looking internationally to enroll sites to make sure that the tests we bring forward, we can stand behind, that they are accurate to detect cancer earlier across a diverse population. The second, as I mentioned, is adoption. Well, we can make the tests available, but people have to use them, and they want to make sure that they come back and get screened again. We're now working on ways to make sure that not just are we making the test available, but that we're communicating with patients in the way that they want to be communicated with, whether that be being in the communities and doing health screens with local health system partners, whether that be text messaging people and communicating in what they're most used to. We need to make sure that people adopt the technologies that are available. And then the last, which I think hits on this inequity point the most, it is access. How do we make this available in the communities that are in most need of these screening programs? And making things easy is as important as making them accurate. While our job at Exact is to bring the best test forward, we want to make sure that it's so easy to access and so easy to get out into the communities, so easy to meet those patients where they want to be met. There's a certain population that are coming in for their annual physicals every year. We need to make sure that those tools are available at the provider level when people come in for their annual wellness exam. Unfortunately, there's many that don't go to the doctor, and instead they're going to other places to seek support or even care. And access is as important as anything else. So we think that if we can design not just tests, but solutions and programs that hit on all 3 of these components in a diverse population, and I mean geographically diverse, gender diverse, and of course, race, accuracy, adoption, and access, we believe will begin to build or bridge that inequity gap.
What about the issue of drawing minority populations in this country into the research itself? Are there tools or ways that you've used to make the populations in the research studies more diverse so that the data coming out of those studies apply to more people?
Absolutely. So first, we know what the general population segmentation is. Our goal is to meet, if not surpass that. So we've got targets for our clinical studies to make sure that they're very much overlapping with the communities that we want to serve. Second, we form partnership with local health systems and with centers like federally qualified healthcare centers. And we go into the communities where we know these patients are in need of screening. We have very active programs. We invest significantly in local partnerships. From our point of view, Exact, we may believe we know how to get people screened or how we get people into clinical studies, but it's the local partners that actually have the relationships in the community. That might be a church, that might be a federally qualified healthcare center, that might just be a local leader, that might be a school, that might be a school superintendent, an American Legion. Those are the partnerships you need to form because they're the ones that actually have the credibility in the community to say, let's get screened and let's participate in these studies so that we can bridge these gaps that you're talking about, Joe.
They're interested to hear you mention faith-based groups and the role that they can play. When I worked for President Obama, we brought in several groups that were reaching their communities through preachers, ministers, priests, and one of them was this marvelous woman who was the wife of the preacher at the largest Baptist church in, I think in the country, but definitely in New York. And she was just very blunt with her parishioners, who were largely a Black population. And she said to them, you can stand on your high horse and you can object to what was done to Black people in the past by medical research, but then you're not going to be part of these studies, and then the medical treatments won't apply to you. So get in there and get part of these studies. And of course, I couldn't say that, but she did. And it was incredible what that did to the participation of studies at Columbia and some of the local medical institutions that were doing research. So I really learned the importance of reaching people through people that they trust, and that there's no reason for them to trust the average medical researcher, but we can make liaisons between the researchers and populations like that. Any other comments on reaching more diverse populations, either geographically or ethnically or by gender?
Well, Jo, maybe I'll build on what Jake said just briefly to indicate that that engagement has to start really at the very level of the discovery of markers that might make it into a cancer detection test. So you have to include geographically, racially, and gender diverse patients when you are looking at the fundamental aspects of the diseases themselves, and to try to be as inclusive as possible then. And I think Exact deserves some significant credit for doing that in their development of Cologuard, and not only doing the science, but publishing it and getting it out in the public eye and in the scientific community to show that markers that are associated with colon cancer don't fluctuate with other racial and demographic variables. Once Cologuard's developed, to get it out into clinical trials that are racially diverse, but it's good to be inclusive, but sometimes you actually need to go deep, and you need to focus on specific populations where you need a sharper level of confidence. And Exact did that with the Cooper study in Black patients. This was done with a Mayo Alaska Native Health Center collaboration led by Diana Redwood. That was a critical piece of evidence in the Alaska Native population, who has the world's highest incidence of colon cancer, double what we see among whites in the lower 48 states. And continuing that work as you refine your test or launch new products is really essential. I want to also applaud another point Jake brought up earlier, which is something we're actively working on here in collaboration with our cancer center, which is engagement of federally qualified health centers. So these are facilities that provide care for uninsured and indigent patients. And so reaching out and getting people screened is important. When you identify test positive patients, having that community connection to then get them into a larger healthcare system to treat them is important, because when they show up in the emergency room with symptoms and more advanced disease, the cost to society is higher, not just the cost to an individual healthcare system.
Great points. So why don't we return to biomarkers, which is sort of the basis for our conversation here. Any more thoughts about the different uses of biomarkers and what it takes to bring biomarkers from the laboratory to the clinic? It's obviously not just the science that matters. We have to be able to adapt the science to methods that can be used practically. So any further comments on what we'll see coming up in biomarkers?
Jo, I think you hit on a really important point. There's kind of three phases of this. There's the discovery, which you heard John Kissel talk about in his laboratory and the work that they're doing at the Mayo Clinic. And that's so important. That's amazing work that's done. Those discoveries are published in peer-reviewed journals, and they're amazing proof of concepts. We can find the needle in the haystack. We can apply this to a population where they were already diagnosed with cancer and determine that, yes, we did a good job identifying them. And that's really important, and that's where it all starts. We need to shift that into what it looks like into a real world setting. And we call that real world evidence. And we need to take those discoveries at the bench and take those discoveries in very carefully designed studies. And we need to get those into collaborations and partnerships in the real world to see, while it worked in this small study, how will it work in a general population where the incidence of cancer is still on a broad basis only 1 or 2%? How does that work in a diverse population when all comers in a prospective fashion are being screened? I wish more people would do it that way. And that's the way clearly we've done it at Exact. Cologuard went through a 10,000 patient pivotal study off, I think it was over 150 different sites. Our Oncotype test, which looks for very unique genomic signatures in a cancer patient's tissue to determine what therapy is best for them. That went through another 10,000 patient study over 9 years. The amount of time and the amount of rigor that goes into generating the evidence beyond the proof of concept is really what makes these tests, I think, such a reality and so powerful. The third step is that you've got to have the infrastructure to then make sure that you can get these tests after discovery, after you've generated your real world evidence, your pivotal study, received your FDA approvals. Well, now you got to have the infrastructure to be able to administer that test in a very easy way. And I think it's understated how much of an investment it takes to make sure that you don't just have your clinical lab operations, but you have pathologists on board if you're looking at tissue, and you have clinicians on board that are helping talk with others about their results. You have a group of people that take phone calls in the middle of the night because they're confused, or maybe they don't know how to pay their bill, you name it. The infrastructure that's needed, the IT infrastructure, how easy it is for a provider to order the test, and then how easy it is for a patient to get the result. That alone is a Herculean effort. And I think it's those three things that come together that make the bar, if you will, just so hard to make these tests, not just at John's lab as a proof of concept, also to get FDA clearance, and then to really make them a reality to get all people screened with those great technologies that we've discovered.
So you're saying that discoveries made today in the lab won't be seen in the clinic for several, if not many years?
Yeah, absolutely. Now, we're looking at ways to innovate those clinical studies. We're trying to get people enrolled in a proactive way. We're talking with the agencies, the FDA in particular, about how can we design studies and trials that bring this up. Those are all things that we spend a lot of time thinking about so that we can accelerate that. But there's nothing that you can shortcut in generating the evidence in the real world to demonstrate the power and the utility and the accuracy of these tests.
And we all know that bringing tests or treatments before their time, before they're totally tested and proven to the clinic can be very destructive because it diminishes patient confidence and develops all sorts of attitudes about science and medicine that we don't need. John, I was curious, as a microbiologist, I can't help asking, what can you tell us about the future of biomarkers and microbes in cancer?
Well, as a microbiologist, you have far greater expertise in this question than I do, Joe. But it's been said that every human being is a trillion and one organism. So there are enormous numbers of invertebrate and microbial life that are on or inside of our bodies, and they often are either drivers or reflectors of our health state. And so there are teams that have used specific bacterial strains or specific bacterial virulence factors. These are sort of the surface proteins of microbes that actually can cause disease in humans as biomarkers of somebody who may be at risk of or may be developing cancer. And then also, once a cancer has formed, and I think this is probably best studied in the colon, the actual composition, the sort of the neighborhood of bacterial families can change. And there are teams that are developing marker panels, primarily out of stool, but also potentially out of blood, that can measure these phenomena, so that we can, again, exploit the biology that's already happening in and around us, to the benefit of humankind.
Very exciting. I think, of course, microbes run the world. So I think the future of microbiology and cancer is pretty bright. One of the experiments that's been done a lot with other conditions like obesity and depression is to take the microflora bacteria from the human gut of people who are suffering from a particular condition and transfer it to mice that are germ-free, that don't have any bacteria in them, and induce the symptoms. And it's a discussion for another day, how you detect depression in mice. That's another story. Has anything like that been done with cancer? Have there been any transfers of microbes that actually can induce cancer in germ-free mice?
Yes, there have. I'm not a particular expert in this area, so my understanding of it may be a little superficial, but it's not just bacterial strains, but actually bacteria that are carrying specific disease-causing virulence factors have been transferred into mice, or transferred from one mouse model to another to induce cancer. So that hypothesis holds up in cancer biology very well.
Very interesting. Anything else people want to add on translating biomarkers from the lab to the clinic? I think we covered that well. Okay, I've only heard one mention, or maybe two, of the government in all of this. And I'm wondering, I think, Jake, you mentioned FDA that has to approve tests and treatments. But are there other things that government can do besides the approval process to foster the kinds of technologies we're talking about today and their very broad use?
Yeah, no question, Joe. So first, as a reminder, Cologuard went through the first ever parallel review, which means that we submitted Cologuard to the FDA and to Medicare at exactly the same time to get approval for both. It's important to get FDA approval. That gives you the stamp of we like this product, it's going to do well, and you can go then market it. You still got to get paid for the work that you're doing. And the largest payer is the government and Medicare. And a lot of these tests that we've talked about on this panel really do target a Medicare population. So we did that. We did that well. But that's not the routine process that is still gone through. It's still a challenge, if you will, to think about doing those types of parallel reviews. While we did it for Cologuard, it's becoming increasingly challenged to do those things. Also, generating the data for both stakeholders becomes difficult. You want to show that the test performs well to the FDA, and then you want to show that the outcomes, or that the cost benefit to Medicare and to the private payers, those are different types of studies and different types of evidence. And so we have to invest in both. Let me give you an example of the challenges that we're trying to work through, Joe. Multi-cancer early detection. There's actually no benefit category right now for Medicare constituents for that type of testing. So not only do we have to design the best test, not only do we have to enroll tens of thousands of patients to show to the FDA that this test performs the way described in a large patient population, but now we actually have to go into DC and we have to work with congressional leaders to make sure that we design legislation that actually gives a benefit category for those people that should get screened and should get tested for multi-cancer early detection, adding yet another layer. We'll work through all of these things to be clear, but it just shows the complexity and how hard it is to break through these things. It's very important that we have the engagement in DC. It's very important that we're talking to the relevant stakeholders so that they understand what's needed beyond the science and beyond the studies. And this is just a great example. The last thing I'll say is today, the way that the world sits, if your test isn't COVID related, it's getting put in the middle, if not at the bottom of the pile. And we understand that, but I'd like to emphasize to everyone listening, we're in a pandemic. I get it, COVID. We actually perform the majority of the state of Wisconsin's COVID testing. So we're in it as a solution provider. Cancer is a long-term pandemic, and we just need to make sure that we don't put off these tests, the screening, but we also have an ability to talk to the FDA and to CMS so that we're not causing undue harm or we're not missing an opportunity to bring this innovation forward because they're backlogged with COVID. That's a concern that we have as a company, and that's something that we're looking to engage with stakeholders like Stand Up to Cancer, institutions like the Mayo Clinic. This is going to take a collaboration or a consortium, if you will, to work through.
Yeah, we need to get other diseases back on the docket. That's absolutely right. Any other last comments before we close our panel? Sung, any last recommendations for the public or for supporters of Stand Up to Cancer or anything else?
I'm really pleased to have been part of this discussion with John, Jake, and you, Jo. And these are exactly the kind of conversations we need to be having across the country. The future of cancer screening and diagnostics is very promising, and it has the potential to stem the tide of cancer as we know it. That's huge. What we do with these amazing innovations is, in the final analysis, up to us and the priorities we make to optimize public health impact and health equity. And it will, as Jake has mentioned, take all of us collaborating, cooperating, and communicating to make new ideas happen for millions of people. So thank you, and I look forward to more of these conversations.
Well, maybe other places in the country will take a lesson from Madison and have panels like this. This has been a wonderful group. John, Jake, Sung, thank you so much for joining us. And I hope our viewers learned as much as I did, because I found this incredibly informative. So thank you for your passion for detection and screening for cancer. And thank you for spending the time with us to share with our viewers your incredible knowledge of the topic.
Thank you very much, Jo.
Thank you, Jo.
Thanks a lot. Bye-bye.
We would like to take another moment to thank our sponsors, whose financial support helps make CapTimes Idea Fest the important event that it is. Special thanks to our presenting sponsor, UBS, the Burrish Group. They have been a major sponsor since the very first Idea Fest. Major sponsors include HealthX Ventures, Exact Sciences, and Quartz. Co-sponsors are Madison Gas and Electric, Godfrey & Kahn Law, the University of Wisconsin-Madison, and Epic. Our Friends of Idea Fest sponsors are Wisconsin Alumni Research Foundation, Madison Community Foundation, University Research Park, Cargo Coffee, Doc Smokehouse, and Forward Theater Company. Our media partners are the Wisconsin State Journal, Madison.com, WKOW Channel 27, and Hinckley Productions. Again, we thank you for your support and for making Idea Fest 2021 a huge success.